Hello. Let's continue our discussion on ischemic heart diseases with chronic stable angina. But before we move on to chronic stable angina, I would like to discuss that little bit of a topic that we had in our question prior to this, which is Prince metal or variant or vasospastic angina. Prince metal variant angina or vasospastic angina is a peculiar type of angina which usually occurs in young male smokers. It's young male smokers who are usually associated with this condition, and they come to you with angina that is not classically precipitated by exertion. Many a times, this occurs at rest. When the patient comes to you, you look at a patient and he's going to come to you with anginal pain. Your natural response would be to do an ECG. When you do this ECG, you usually will see elevation of the ST segment in leads 2, 3 AVF. That is, those leads that are looking at the inferior surface of the heart, usually supplied by the right coronary artery. And when you see this, your natural response would be this is a little unlikely. And many people do have this response. That is why we would tend to repeat an ECG. We do a repeat ECG in many patients, and you would see that the repeat ECG is a completely normal ECG. As the angina passes, the patient will also have the stabilization of the ECG changes, the normalization of ECG changes. This is the classic way in which Prince metal or variant angina is going to present. So you have a young male who's a smoker, no other risk factors, presenting to you with angina and ST elevation, which subsides spontaneously. Both the angina disappears and the ST elevation also subsides. So this has been described as due to vasospasm. This is not really due to ischemia per se, but it is due to vasospasm. So it's called variant or vasospastic angina. The classically a young smoker with transient ST elevation, transient because it was present initially and then it disappeared. These patients, if they go for angiography, will show normal coronary arteries, but especially the right coronary artery territory. If you can give an injection of acetylcholine, that will precipitate a focal coronary spasm. Now, you might be thinking that this condition seems to be rather benign. Why should we bother? But as this shows you, about 20% of these people, even though they are young males, they can suffer from myocardial infarction. Usually, it is going to be a non fatal kind of a myocardial infarction. The patients have to be treated. Most important part of the management would be smoking cessation. And apart from smoking cessation, one very important point you should know is that aspirin should not be used in variant or Prince metal angina. The reason for that, aspirin inhibits cyclooxygenase. Cyclooxygenase, will definitely lead to an inhibition of thromboxane A2 in the platelets. That's good because the platelets will not clump. But as you can see, in Prince metal or variant angina, platelets don't really have a role. It's just vasospasm. Since it is vasospasm, coronary vasospasm, or tightening of the muscles of the coronary artery, the only way you can relieve it is by using vasodilators like nitrates. In fact, if you give aspirin, cyclooxygenase, which is also present within the endothelial cells, there it leads to formation of prostacyclins with a vasodilators. So if you inhibit prostacyclins in variant angina by giving aspirin, it might worsen the ischemia. So remember this very important point. In Prince metal angina or variant angina, aspirin can actually worsen the angina. Right? So the management is primarily going to be nitrates, calcium channel blockers, and smoking cessation. That takes care of most of your patients. Even if they do have myocardial infarctions and they do not abide with your treatment and they do have myocardial infarctions, it's usually a mild, non fatal myocardial infarction. So, if any patient approaches you, a young patient, young male patient who is presenting with, yes, transient anginal chest pain and ST elevations, your first diagnosis should be Prince metal angina. Remember, no aspirin there, but go ahead and give calcium channel blockers or nitrates. With that, we can now move into the topic of our discussion, which is chronic stable angina proper. We would start off discussion of chronic stable angina by defining what chronic stable angina is. Following that, we would move into the rather difficult process of really diagnosing chronic stable angina. Chronic stable angina, like all ischemic heart diseases, one of the best ways to diagnose would be to do an angiography. But in chronic stable angina, because it's a very common condition, you cannot do angiography in all patients. It's an invasive procedure. You also have a very important role for non-invasive testing of chronic stable angina, which we will discuss in detail. And finally, we would move on to management. So first things first, let's define what is chronic stable angina. So I'm sure all of you remember this idea of an atherosclerotic plaque which produces a demand supply mismatch. And once you have a demand supply mismatch, you develop the chronic stable angina. Right? When we use the term a chronic stable angina, let's define chronic stable angina. Now, chronic stable angina, has three components. One is the nature of the pain, right? You have a crushing retrosternal pain with Levine sign, which is usually radiating to the left side of your arm, your jaw, etc. And it is usually associated with diaphoresis. We've discussed this in the past. The second important point about the chronic stable angina is the aggravating and relieving features, that it aggravates with exertion, it aggravates with stress, and it is usually relieved with rest and nitrate. So these are the points that you need to remember as far as the aggravating and relieving features. So very classical features about the nature of pain, about the aggravating and relieving features, and we can then look at the duration of pain. Right, the pain, very clearly, chronic stable angina, the pain does not last beyond 15 minutes. In some books, it even is given up to 20 minutes, but it is a pain that usually subsides between 15 to 20 minutes. Mostly, it's only 5 to 10 minutes. If it goes beyond that, you know that there is likely to be a vulnerable plaque rupture. So that becomes acute coronary syndrome. Chronic stable angina, you are primarily facing a demand supply mismatch. There is no vulnerable plaque rupture here. So vulnerable plaque rupture can happen in any patient of chronic stable angina. That is, any patient of chronic stable angina can develop an acute coronary syndrome. But we'll start by discussing the chronic stable angina in this session. So remember, when we say chronic stable angina, it should satisfy these three conditions: classical nature, aggravating and relieving features, as well as the duration of the pain. This is how you define chronic stable angina. Now, diagnosis of chronic stable angina gives a few peculiar problems. And the most important problem there is, unlike acute coronary syndrome, if you do an ECG, you do not pick up findings because ischemia is as a result of demand supply mismatch. So, if the patient is not going to put an exertion, the demand is going to be limited. There is not going to be any ischemia. Patient will not have any chest pain. Patient will not have any ECG changes. So, this is the biggest issue with the chronic stable angina. The ECG changes are not present at rest. So, when the patient walks into your OPD and you're going to do an ECG, you might not see anything, right? So the patient is going to tell you that I have the classic features of chronic stable angina. He's going to tell you the classic nature of pain, the radiation, the aggravating relieving features, the duration of pain, everything fits into chronic stable angina. But this gentleman comes and tells you, see, I have a pain over here, but when you do the ECG, you find nothing. And that's what you expect. When you do an ECG of a patient of chronic stable angina, you don't see anything because the ECG is not being done at the time when he has ischemia. So now the question is, since he has the history suggestive of chronic stable angina, should you go ahead and confirm that there is an obstruction? Confirm that there is a plaque. Of course, the way to confirm it is to go for an angiography. Now, an angiography is an invasive procedure. Not everybody would like an invasive procedure done. So, when you want to do an angiography, you will have to select your patients carefully. You don't want to do an angiography in all the patients. You would want to select those patients who are at high risk. Who are at high risk. So, we don't do an angiography in everybody, but we look at something called the pretest probability, right? So, before you are going to do an angiography, you would want to see how likely is this person to have chronic stable angina. Okay, we can calculate something called pretest probability of the patient having chronic stable angina by looking at the clinical features itself. You already know that the classic clinical features of chronic stable angina involve the nature of pain, the aggravating relieving features, and the duration of pain. If all three features, that is the nature, the aggravating relieving features, as well as the duration of the pain, fits into the classic pattern, we will call it typical angina. That is, all three out of three conditions satisfied: nature, aggravating relieving features, and the duration of pain. All three are satisfied, we call it typical angina. If only two out of the three are satisfied, we say, okay, this is not as likely to be chronic stable angina. We say it is atypical angina. And if only one out of these three features are positive, then we would say that this seems to be non-anginal chest pain. So this gives you an idea of clinically what is the likelihood of this person having chronic stable angina. Other important features apart from the clinical presentation that you can involve in calculating a pretest probability of the patient having a disease would be age of the patient and gender. You know that it's more in men, we know that it's more in older people. So putting gender, age, and clinical features together, we can determine the pretest probability. So if you look at this, you can see that as the age increases, the probability increases. Typical angina, that is 3 out of 3 positive, the chances of the patient having the disease are more. Atypical, much lesser chances. And if it is a non-anginal chest pain, you can see that it's all in the blue. What does these stand for? So if you look at this, you will see that the red stands for very high probability. So very classically, you would be able to see that those patients who are in the red, these are those with high probability. So see which group they fall. From above down, they fall in those who are having typical angina, and the oldest group, especially men. Right? So typical, all three features of anginal chest pain there, predominantly male patients, and they are having older age. These are the patients who are highly likely to have it. Non-anginal chest pain, as you can see in the far right of your screen, those patients, men, women, less likely to have. Anginal chest pain, older men, even if it is atypical, you will think, oh, maybe this guy can have it. So in the red, we have those patients who have very high probability, right? Yes. So this is, we have the red, pink, and blue. The red is high probability, more than 85% risk of having chronic stable angina. Intermediate is somewhere between 15 to 85% probability of having chronic stable angina, and the blue is very low probability, less than 15%. So what we do in these patients is to classify them according to this risk and pretest probability. So here you can see that we have classified it in such a way that the pretest probability of less than 15%, these people are less likely to have chronic stable angina. We say that they are most likely having some kind of non-anginal disease. We don't need to evaluate them any further. Now, if you look at those patients who are very high risk, more than 85%, these are those patients who are very high risk of chronic stable angina. Don't need to do any more testing. Take the patient up for an angiography. Then there are those patients who fall between 15 to 85%. In these patients, we would prefer not to go for an invasive testing. Instead, we would look for non invasive testing, right? And if the non invasive testing turns out, we'll see that there's a whole list of non invasive tests. We will deal with them one by one. If the non invasive tests turn out to be positive, we can, of course, go ahead and do an angiography. If the non invasive testing is negative, we will wait and try to do an medical therapy before we plan an angio. So angio is not necessary if your chances in 15 to 85% risk, intermediate risk category, if there is less likely to be a vascular plaque, we might not do an angio. But if the non-invasive tests are showing a high likelihood of having a plaque, we would go ahead and do an angiography.